Commonwealth Pharmacists Association. He is also a member of the AHAPNI, member of Young African Leaders Initiative. His research interest is in infection, prevention and control disease, prevention and health education, medical waste management. He's going to be talking to us today on pharmacotherapy of Kaposi Sarcoma, pharmacist role. Our presenter, if you are there, please can you unmute yourself and start? Thank you very much.
Okay, good evening, everyone. I don't know if everyone
yeah, good evening, sir.
Yes, please. My name is Pharmacist, and I'm going to talk on the role of pharmacists in the pharmacotherapy of Kaposi Sarcoma. I wanted to ask who is the one sharing the slides?
You are a host now. You can share your slides.
Okay. Okay, just a moment. The slides will be on. Wow, it's telling me unsupported document type. Please select an image or PDF document.
Did you send your slide to anybody, any of us?
Yes, I did.
Who did you send it to? Is it to Dr. Regina James or?
Yes, I sent it to Dr. Regina James.
Okay, all right. Dr. Regina, if you are here, please can you send it to Dr. Bello so you can help us share it?
It is on the education committee group.
Okay, it's on the education committee group. Let me check.
Yes.
The slide is there. So, Dr. Bello. Sorry, let me. Presenter, please can you just go ahead while we try to share the slides? I guess you are seeing your slides. You can just go ahead, and when the slide come up, we'll go to the page that you are.
Okay,
Thank you.
you're welcome. Mm, I am very sorry for the delay. And like I said earlier on, I am going to talk on the role of pharmacists in the management of Kaposi Sarcoma. And the outline is going to be an introduction. What is Kaposi Sarcoma? Pharmacotherapy of Kaposi Sarcoma, the role of pharmacists. And I will do a case review, a comprehensive case review, which we are managing at the University of Uyo Teaching Hospital. Then a conclusion, glossary of terms and references. As an introduction, Kaposi sarcoma, which in the course of this presentation I'll be referring to as KS, is a disease in which cancer cells appear on the skin and on the mucous membranes. It can also be found on the lymph nodes and the lungs. It is important to note that Kaposi sarcoma is more common in men than in women, and also in patients with suppressed immune systems like immunocompromised patients like HIV positive patients, like organ transplant patients who are on immune suppression to avoid organ rejection. Early diagnosis and pharmacotherapy can improve outcomes and lessen the risk of the KS disease spreading to other organs. As in, for the pharmacotherapy of all diseases, especially in this case, pharmacists have important roles to play. So what is Kaposi sarcoma? Like I said earlier on, it is a tumor that is derived from endothelial and immune cells infected with the human herpes virus type 8. So it has been identified that it is the human herpes virus type 8 that is the causative agent of Kaposi sarcoma, as it is present in almost 100% of the cases identified. So the history and epidemiology of Kaposi sarcoma, it was first described in 1872 as a rare disease in the Eastern European main. In the 1950s, an endemic form of Kaposi sarcoma was reported in Central Africa, affecting men, women, and children. In the US, it is estimated that the risk of Kaposi sarcoma in people living with HIV is 500-fold higher than the general population. And it is notably that after the AIDS epidemic was identified in the early 80s, the incidence of Kaposi sarcoma in Africa increased markedly. Here in Nigeria, Kaposi sarcoma was relatively uncommon before the HIV pandemic, but it is now being reported as the most common malignancy in males in certain subpopulations of Nigeria. That study was done in the National AIDS Incidence Study of 2018, in which the prevalence of HIV was elucidated. It was noted that of the people who are living with HIV, it's only 47% that have been identified, of which 96% of the 47% are on treatment, and viral suppression is achieved in only 86%. The overall crude Kaposi sarcoma prevalence of 5.9 per 1,000 is being reported among Nigerians living with HIV/AIDS. And that study was done by Akanbi and others at the Jos University Hospital, a retrospective study of between 2006 and 2017 of cases reported, HIV positive cases reported at the Jos University Hospital. It was published in this 2022. So what are the signs and symptoms of Kaposi sarcoma? Lesions, that is ulcers, may involve the skin, the oral mucosa, the lymph nodes, and visceral organs. Visceral organs are especially the lungs. Most patients present with skin disease, just the cutaneous disease, but a few others present with both the skin and the visceral organ disease. Nearly all lesions are palpable and non-pruritic. That is, if you see these lesions, you can feel them with your hands and they are non-itching. The lesions may range in size from a few millimeters to several centimeters in diameter. As we go on, we are going to look at a few pictures that will give us a clearer view of Kaposi sarcoma. Lesions may assume a brown, pink, red, or violaceous color and may be difficult to distinguish in dark-skinned individuals. Since the lesions of Kaposi sarcoma are hyperpigmented, it might be difficult to really distinguish it in people who are dark-skinned. Lesions may be discrete or confluent and typically appear in a linear symmetrical distribution. It is good to note at this point that it is of the same family of herpes zoster that this herpes simplex also comes from. So it also follows that linear and symmetrical distribution. Mucous membrane involvement is common, and this includes the palate, that's the mouth, the gingiva, and the conjunctiva of the eye. Gastrointestinal lesions can occur anywhere in the GIT, and lesions are often asymptomatic and clinically indolent. Here I have there are pictures of Kaposi sarcoma presentation on this particular slide. One of the pictures, it is prevalent on the face and the chest. At the other picture, it is at the chest region. As you can see, it's hyperpigmented and it is prominent. On the fourth picture, it is on the ankle of the leg. So how is Kaposi sarcoma diagnosed? First of all, the CD4 lymphocyte counts and plasma HIV viral load studies are done because, like I said earlier on, it is prevalent in immunocompromised patients. So the first thing is to do a CD4 lymphocyte count to know how much of the immune cells are remaining in the patient. And if the patient is HIV positive, a viral load study is done to know how the burden of the HIV on the patient. Also, for patients who have Kaposi sarcoma of the lungs, chest radiograph, chest X-ray might be done to elucidate that. And for the lesions, that's the ulcers, the wounds, the Kaposi sarcoma wounds, a typical biopsy will be done so that histologic findings conclusive of Kaposi sarcoma is done. And that is shown on the film by proliferation of spindle cells and the extravasated red blood cells, prominent slit-like vascular spaces. There is a slide here that talks about the staging of Kaposi sarcoma. That is talking about the good risk and the poor risk. The good risk staging of Kaposi sarcoma shows a very high incidence of recovery, almost 100% recovery. Whereas the poor risk there might be an increase in hospital stay and the recovery rate is low. For the good risk, the tumor is confined to the skin alone or just the lymph node, and the CD4 count is greater than 150 per millimeter cube. And in the good risk, there is no history of opportunistic infections and no history of 10% involuntary weight loss, or there are no diarrheas that are persisting more than 2 weeks. But in the poor risk, the tumor has spread already and it is associated with edema or ulceration. In the good risk, the tumor is intact. It hasn't burst, there are no ulceration, there are no wounds. But in the poor risk, there is ulceration. This patient, which we are going to see a presentation in our presentation later on, it was a poor risk. Immune system CD4 count is less than 150, and there's history of opportunistic infections. In the case that we will see, the tumor has already broken into ulcers and the CD4 count was less than 200 per millimeter cube, and there was history of esophageal candidiasis, which is an opportunistic infection of HIV. How is Kaposi sarcoma managed? Currently, there are no standard treatment protocols available to eradicate the herpes virus 8 infection. Therefore, there are no cure for Kaposi sarcoma. Instead, the purpose of therapy is just to alleviate the symptoms and slow disease progression, except for the good risk of which the prognosis is good. Treatment decisions vary depending on the Kaposi sarcoma, presence of symptoms, and extent of disease. Most good risk patients show tumor regression with a highly active antiretroviral therapy alone. Poor risk patients usually require a combination of chemotherapy and the antiretroviral therapy. Antiretroviral therapy has changed the therapeutic goal in Kaposi sarcoma from short-term palliation to long-term remission and control. So we have, for the therapy, we have antiretroviral therapy, we have local therapy, we have immune modulation, we have combination therapies. And for the antiretroviral therapy, we all know that optimal control of HIV infection using highly active antiretroviral therapy is an integral part of the successful therapy of Kaposi sarcoma. And for low risk patients and for good risk patients, the antiretroviral therapy alone might be the sole modality. For local therapy, you might have surgical excision of the Kaposi sarcoma, you might have radiation therapy, cryotherapy with ice, laser therapy, or you do topical retinol. These are creams. For immune modulation, there is interferon alpha, which has shown clinical activity against Kaposi sarcoma. For the combination therapy, this is especially in the poor risk patient. We do a combination of both the antiretroviral therapy and chemotherapy, that's anti-cancer medication. And the most used regimen is the actinomycin, bleomycin, and vincristine combination. And it gives an overall high survival rate. The cytotoxic agents include the paclitaxel and the daunorubicin. So when we talk about the pharmacotherapy of Kaposi sarcoma, treatment considerations include observation. For people that are being diagnosed with Kaposi sarcoma and they are good risk, and you check they are HIV negative, the first step is just to observe. And patients are observed over time, especially those who have asymptomatic lesions. Treatment of early AIDS-related Kaposi sarcoma should start with antiretroviral therapy. So the mainstay is antiretroviral therapy first, which often results in the Kaposi sarcoma regression, as we will see later in the case review. Localized nodular disease may respond well to surgical excision, radiotherapy, and intralesional and outpatient low-dose vincristine chemotherapy. The choice of topical therapy depends on the site and extent of the disease and on individual patient status. So, for example, the patient is RVS negative, and the Kaposi sarcoma is limited on a very small portion of the skin, and it's only cutaneous. It does not have any visceral organ involvement. Then you can just do a topical therapy, and that would solve the problem. In children with both Kaposi sarcoma and HIV infection in sub-Saharan Africa, ART together with the chemotherapy regimen appears to be better than the use of either ART or chemotherapy alone. So apart from patients who are HIV positive, we also have post-transplant patients who, because of immunosuppression therapy, come down with Kaposi sarcoma. And the use of mammalian target rapamycin inhibitor or together with chemotherapy can also give them a good remission. Chemotherapy concentrations include systemic vinblastine, We have topical imiquimod 5% cream applied 3 times weekly for 24 weeks. The systemic vein blasting is given 4 to 10 milligram IV weekly. And paclitaxel is also good at the dose of 80 to 100 milligram per meter squared IV. That is body surface area. We also have oral etoposide, which is an effective treatment containing KS and improving quality of life. We also have paclitaxel plus ART, and we also have pomalidomide. So in patients with Kaposi sarcoma and HIV, antiretroviral therapy with or without local Kaposi sarcoma therapy is employed with interferon alpha if the CD4 cell count is less than 200. So what are the role of pharmacists? The role of pharmacists have evolved and expanded in recent times. Pharmaceutical care ensures that the medication needs of individual patients with Kaposi sarcoma are met by the pharmacist. Therefore, for Kaposi sarcoma, the pharmacist appraises and dispenses prescriptions to Kaposi sarcoma patients. So for every prescription that comes, it is going to be appraised fully, appraised wholly for all the drug therapy problems, whether real or apparent, and such prescriptions are dispensed with utmost care and precision. Also, the pharmacist detects and manages drug-related problems. Apart from the drug therapy problems, the 8 drug therapy problems, there might be other drug needs the patients might have or other needs that are drug-related. The pharmacist is expected to meet these needs. We're going to see exactly this in the interventions made in the case review. The pharmacist instructs and advises Kaposi sarcoma patients on how and when to take prescribed medication and informs them about potential side effects they may experience. This improves adherence. In the case review that we are going to see, the patient was within a 1 month stay in the hospital. The patient was prescribed about 24 different medications, and it was the pharmacist's intervention in the timing and interval of medication administration that helped the patient not to experience many side effects or drug-drug interactions. Also, the pharmacist consults with physician consultants, residents, nurses, and other healthcare providers who are managing the Kaposi sarcoma patients and the medications. The pharmacist also advises other healthcare practitioners about proper medication therapies for Kaposi sarcoma patients. So for the case review, I hope we are all together. Hello?
Yes, we are. Yes, we are. We are together.
Has the slides come up now?
Yeah, it has. We are seeing your slides. Yeah.
With speed on down there in Casablanca.
Okay, so for the case review, there is this patient, IAO, who is 49 years of age, male, Christian, public servant, who presented to our facility with complaints of itchy penile ulcers and swollen scrotum for 1 year. Medical and family history. The patient is not a known hypertensive, not a known epileptic, asthmatic, diabetic, or sickle cell patient. And there is no family history of any of those diseases. Medication history. Within the 1 year, this patient had these penile ulcers and swollen scrotum. He had taken several antibiotics of which the names could not be recalled, and had also taken herbal enema for hemorrhoid he had within this period of 1 year also. The medication history continues that there is no known food allergy. However, for drug allergy, the patient reacts to sulfonamide, metronidazole, and reacted to ceftriaxone in the course of therapy here in the hospital. The patient is a newly diagnosed HIV positive patient who is regular on HART for the past 2 months. On examination, that's objective, that the patient was pale with nodular growth on the mons pubis, hyperemic and firm. The phallus, that's the penis, is edematous and hard with ulcers. No abnormality was detected in other systems that were reviewed. Several investigations were ordered, and the ones that were significant for the therapy was that the wound swab MCS of the phallus and the mons pubis yielded heavy growth of Escherichia coli, which was highly sensitive to ciprofloxacin, levofloxacin, and ceftriaxone sulbactam combination. Urine MCS was also done during microscopic culture and sensitivity. It yielded moderate growth of Staphylococcus aureus, highly sensitive to erythromycin, ofloxacin, and ceftriaxone sulbactam. A liver function test was done, and the liver enzymes were elevated, although the abdominal ultrasound scan ordered for showed that all internal organs, including the liver, were without abnormalities. Also, a retroviral screening was reordered, and a triple screening showed positive for all three test strips. The CD4 count was done, and it was less than 200. The PCV on admission was 19.4, which after 8 units of fresh whole blood being transfused increased it to 30 as at discharge. So with this examination and the investigation results, the physicians gave an initial diagnosis of corneal gangrene in background stage 2 retroviral disease with a queried penile cancer. But when the sample from the phallus and the mons pubis, the ulcers, was sent for histology, the weight biopsy showed Kaposi Sarcoma with involvement of the margins, which necessitated a change in diagnosis to RVD stage 4 with Kaposi Sarcoma. Patient later developed deranged clotting profile and esophageal candidiasis and malaria on admission. So the physician's plan was to transfuse 4 units of fresh whole blood immediately and continue transfusion with further units of fresh whole blood until PCV increased to greater than 30%. Then another 2 units of fresh whole blood prior to chemotherapy. However, due to the deranged clotting profile, patient was administered 2 units of fresh frozen plasma to correct the clotting profile. Sit bath for scrotal wounds was ordered for and done on a daily basis till patient was discharged, and daily dressing of the penile and mons pubis wounds was done with sulfratide for the 1 month that the patient was in the hospital. The following drugs have been in use. At the point of admission, patient was prescribed intramuscular tetanus toxoid 0.5 ml stat, tablets vitamin E 400 international units daily, tablets vitamin B complex 1 tablet 8 hourly, tablet ferrous gluconate 1 tablet 8 hourly, tablet vitamin C 1 gram daily, intravenous ceftriaxone 1 gram 12 hourly, and intravenous levofloxacin 500 milligram daily. However, on continued administration of this medication, patient was seen to have vomited and he was nauseated excessively up to the point that patients was not able to tolerate oral feeds and oral medications for about 24 hours. And that adverse drug reaction was traced to ceftriaxone and also to the antiretroviral therapy, which is further down. So in that case, the ceftriaxone was discontinued, but the levofloxacin was continued to manage the Escherichia coli and staph aureus that was isolated from the patient sample. Because of the esophageal candidiasis, the patient was having a frequent irritating cough. So syrup Ascorex 10 ml 8 hourly was prescribed. Because of the pain, it is worthy of note, and I have to emphasize that Kaposi Sarcoma comes with a lot of pain, especially when it has broken into ulcers. This patient was passing through excruciating pain. Initially, intramuscular diclofenac 75 milligram was given as a start dose and continued with TAPS diclofenac 50 milligram 8 hourly. But after a period of about 3 days, the pain was not well relieved. So in that case, intramuscular pentazocine 30 milligram 8 hourly for 1 day was added to continue with CAPS tramadol 50 milligram 12 hourly. This tramadol 50 milligram 12 hourly was to be given concomitantly with the TAPS diclofenac 50 milligram 8 hourly. And that is what gave the patient better pain management. Because of the vomiting that ensued, usually after administration of the antiretroviral therapy or after the administration of the ceftriaxone had to be discontinued. But since antiretroviral therapy is an essential component of this patient's therapy, ondansetron 8 milligram tablet was added and was to be taken 30 minutes before the antiretroviral therapy was given. Because of the esophageal candidiasis, tapsmestatin 500,000 international units 8 hourly was added. And the highly active antiretroviral therapy for this patient was abacavir, lamivudine, dolutegravir, and each of them was to be taken 1 tablet in the morning. So for this patient, it was the highly active antiretroviral therapy was taken by 6 in the morning, while the ondansetron was taken by 5:30 in the morning. For intermittent preventive therapy of tuberculosis, TAPS isoniazid. Intermittent preventive therapy for tuberculosis, isoniazid was added at 300 milligrams to be taken in the evenings. Taparidoxine 50 milligrams daily was given in addition to the isoniazid to prevent isoniazid-induced neuropathy. TAPS cotrimoxazole 960 milligrams was given daily as a prophylaxis for pneumocystic carinii pneumonia, which is one of the complications of HIV and opportunistic disease. In the course of therapy, the patient developed fever and the malaria test was done, showed positive +1. So intramuscular alpha beta theta 450 milligrams was administered daily for 3 days, after which TAPS atenolol lumefantrine 80 to 480 milligrams was given twice daily for 3 days. IV paracetamol was also added to the antimalarial therapy at 600 milligrams 8 hourly for 3 days. Because of the deranged clotting profile of the patient, apart from giving platelet infusion. The patient was also prescribed intramuscular vitamin K 10 milligram daily for 5 days. This happened especially because the patient was stooling blood after a while. And also IV tranexamic acid, 1 gram TBS was given. Suppository diclofenac 100 milligram 12 hourly was given later on in the therapy. That was when the oral fix or medication was not being tolerated. So what are the rationale for drugs used in this patient? Tetanus toxoid was used for active immunity against tetanus infection at the penile and pubic ulcers. Ceftriaxone and levofloxacin. Ceftriaxone is a third generation cephalosporin, whereas levofloxacin is a quinolone antibiotic. And they were used as antibacterials against E. coli and Staph aureus isolated from the penile and pubic ulcers. Vitamin C and E are potent antioxidants used to facilitate wound healing in this patient. Vitamins B complex and ferrous gluconate are hematinics used in improving red blood cell production. Paracetamol, diclofenac, pentazocine, and tramadol are analgesics. Paracetamol and diclofenac are used for mild to moderate pain, whereas pentazocine and tramadol are used for moderate to severe pain. They were used to relieve pain in this patient. Nystatin is an antifungal used to treat esophageal candidiasis. Ascorix is a cough syrup containing salbutamol used in relieving the cough and bronchoconstriction caused by the esophageal candidiasis. Abacavir, lamivudine, and dolutegravir is a highly active antiviral therapy used as a first-line drug, first-line anti-HIV in the management of HIV infection. Ondansetron is an antiemetic used in preventing the vomiting side effects of abacavir and lamivudine. Isoniazid and cotrimazole are intermittent preventive therapies for tuberculosis and pneumocystis carinii pneumonia, respectively. Pyridoxine is used as prophylaxis against isoniazid-induced neuropathy. Alpha, beta, theta, and artemether-lumefantrine are anti-malarial used in the management of malaria in this patient. Vitamin K and tranexamic acid are hemostatics used to arrest gastrointestinal bleeding as fresh blood was seen in the patient's stool. What are the pharmaceutical care goals? The goals developed by the pharmacist in the management of these patients included to promote healing of the penile and pubic lesions, to alleviate pain at wound site, to ensure rational drug use for management of AIDS and Kaposi Sarcoma, to enhance immunity, to reduce hospital stay, and to improve the patient's quality of life. The pharmaceutical care plan was to ensure the appropriateness and availability of all prescribed medications. As in this patient, there were a few of the medications that were not available in the hospital. And the pharmacist that was in charge of this patient to ensure that it was speedily procured from pharmacies outside the hospital, so that this patient did not have either missed doses that would have made his hospital stay increased. The care plan included to counsel patients on the need to adhere strictly to prescribed medications and administration times. Like we are going to see very soon, the medications were staggered in such a way that interactions was avoided. The care plan included to encourage patients to purchase the chemotherapy drugs and take the required courses when prescribed. All through the patient's stay in the hospital, chemotherapy was not necessary because the highly active antiviral therapy, together with other medications, were enough to heal the Kaposi Sarcoma lesions. To encourage patients not to be worried about his health condition by educating patients on the disease condition. Patient was comprehensively counseled and educated on his disease state and encouraged not to be worried. The drug therapy problems in this case, the actual drug therapy problem was that the patient developed adverse drug reaction with metronidazole, that was lethargy and dizziness, and with ceftriaxone, severe nausea and vomiting, and these drugs were discontinued. Need for additional drug ondansetron to alleviate the vomiting adverse effects of the abacavir and lamivudine. Inappropriate adherence to oral medications due to severe vomiting for about 24 hours. And the potential drug therapy problem is drug-drug interactions, which may be occasioned by polypharmacy. As you can see, 24 different drugs were administered within a 30-day hospital stay of this patient. What were the pharmacist's intervention? In this case, the role of the pharmacist was really felt in the ward. And it is important to state here that both the patient, his caregiver, the nurses, the physicians were all appreciative of the input of the pharmacist in this case. Because apart from the pharmacist establishing a collaborating relationship with the patient, his caregiver, and other members of the healthcare team, resulting in daily bedside review visits, the pharmacist dispensed medications in a patient-focused manner, taking that patient as the most important patient in the hospital at that time, as is done with all other patients, making the patient feel that special care, including medications that were not available in the hospital pharmacy. All medications were made available for the patient. The pharmacist provided medication counseling to the patient and his caregiver, especially on the timing of medications. And this was done in agreement with the physicians and the nurses, because we saw that a lot of medications that were done could have resulted in drug-drug interaction. The pharmacist conducted patient symptom assessment, eliciting poorly managed pain and vomiting, which necessitated add-on medications, tramadol and ondansetron. On the third day of the patient's admission in the hospital, the patient still complained of excruciating pain, even after being on diclofenac intramuscularly, that was followed by oral diclofenac 15 milligram 8 hours. So on that event, the pharmacist intervened, discussing with the physicians that were managing the patient that there was a need for an add-on medication, since the patient's pain was not just mild and moderate, it was between moderate and severe. And that was what necessitated the addition of IV pentazocine, which was followed by tramadol. Also, when the patient complained of a daily vomiting episode, even after the discontinuation of ceftriaxone, and the patient complained that it is usually within a few minutes after taking the antiretroviral therapy. So I just checked it up, and I knew that the abacavir and lamivudine can cause adverse effects of vomiting in as much as 10 to 20% of patients. So this my patient fell into that category. So also the physician was notified, and ondansetron was added to be taken 30 minutes before the antiretroviral therapy. When patient wasn't tolerating orally for about 24 hours, the pharmacist intervened for IV fluids to be reconstituted and essential medications converted to injectables. So the patient could not eat anything and could not take his oral medication for about 24 hours. The patient was so weak. The patient blacked out on his way to the urinary. And when I went on one of my visits, he told me that I just reached out to the team of physicians managing him, and IV dextrosaline was instituted to give him the energy and the fluid resuscitation he needs. Also, some of his oral medications was converted to injectables. So with empathy, the pharmacist instilled hope in the patient and his caregiver on the prognosis of the disease condition. What were the outcomes? The clinical outcome was fair because the symptoms of pain and vomiting were resolving. Also, the ulcers were healing as at the point of discharge. The patient was asked to go home and to visit the clinic on regular intervals for dressing on that's 3 times a week, on Mondays, Wednesdays, and Fridays for dressing of the ulcers. Economic outcome was good because the caregiver was able to prepare all prescribed medications and carry out all investigations. The humanistic outcome was good because the patient and caregiver were satisfied with the level of care provided. On the whole, the therapeutic plan was fully implemented for this patient. So in conclusion, Kaposi sarcoma is a very rare cancer that causes lesions to grow on the skin, lymph nodes, internal organs, and mucous membranes, lining the mouth, the nose, and throat. It often affects people with immune deficiencies, such as HIV or AIDS or organ transplant. Treatment may include radiation, chemotherapy, including antiviral therapy or surgery. So because drugs are used in the management of Kaposi sarcoma, pharmacists have roles to play, as has been outlined here, for the efficacy and safety of the drugs to be assured. Thank you very much for listening. I have a glossary of terms and acronyms used here, and I also have my references here. Thank you. Thank you very much.
Thank you very, very much, Pharmacist Ikemesi Ekong Udo. We really appreciate this, your wonderful presentation, and most importantly, giving us a case study. Thank you so much. You've been able to let us understand what Kaposi sarcoma is, and you also went through the pharmacotherapy, and because drug is involved, the role of pharmacists, you were able to spell it out. Thank you very much. Before I go ahead, I want to use this opportunity to recognize the national chairman, Dr. Joseph Madu, who is also present here tonight. Sir, you are highly welcome.
Thank you very much, Dr. Timi. Good evening, everyone. God bless you.
Sir. Thank you very much. So at this point, without wasting time, let's just go to questions. But before we do that, I've been on the chat post, on the chat, some persons have been sending a question. I think Pharmacist Saka, the patient is allergic to sulfonamide and ceftriaxone, hence not a candidate for cotrimazole and ceftriaxone. Was the cause of bleeding investigated? If traceable to the NSAID, why use suppository diclofenac? I don't know whether we should answer this one first before we allow any other person to start asking questions. Our presenter, are you there?
Yes, I am here. I am here.
Okay.
Yes.
All right. Can you respond to those questions on the chat?
Okay, I can. Patient is allergic to sulfonamide. Was a report from the patient, hence not a candidate for Cotrim. But we did a test dose of Cotrim administration, and the patient did not react to it. We did not collaborate the information the patient gave us. The patient just said he reacts to some drugs, and he said what doesn't remember the names of the drugs. He mentioned the tablet shapes and sizes, and it was just assumed. It was just assumed by the physician that was clerking the patient at the moment that it was sulfonamide the patient is allergic to. But on admission in the hospital and on test dosing, it was discovered that the patient was not actually allergic to cotrimoxazole. So the patient continued on it without any issues. Yes, the cause of bleeding was investigated. In this case, the bleeding could also come from Kaposi sarcoma lesions in the GI tract because mucous membranes are involved, and also could have also come from the suppository diclofenac. Immediately GI bleeding was noticed, suppository diclofenac was discontinued. It was discontinued, although oral diclofenac was still given together with the tramadol tablet. The GI bleeding subsided on its own immediately after the discontinuation of the suppository diclofenac.
All right, thank you very much. Do you have any other comments, questions, contribution? Please, you can indicate by raising up your hand so I can unmute and comment. Yes, Dr. Annie Imoru, please can you unmute yourself and speak?
Hello, good evening, everyone. Thank you very much, presenter, for this lovely presentation and for the elaborate case study that you presented. And
Thank you
thanks
very
to
much.
the moderator, and thanks to CPAM for giving us this opportunity. Among the pharmaceutical care goals, I observed that one of the goals were to reduce hospital stay. I want to ask, how do you measure reduced hospital stay? How is it measured
Answer.
in your facility?
Look at Dr. Chidomuke.
And then another thing I noticed, I don't know if I stand to be corrected though, but there was some investigations that were done for the patient for the wound swab and the urine MCS, and there were some sensitivity results, and it showed that it was sensitive to some particular antibiotics, but I don't think I saw those antibiotics in the list of drugs when you were reading out the therapy. Was there any reason for that? So that's my question. Thank you very much.
All right, thank you. Thank you very much. So you can go ahead and respond to the question.
Okay. In the pharmaceutical care goals, to reduce hospital stay was one of it. How is it measured in our facility? When I went to the admissions and discharge unit to get an incidence of Kaposi Sarcoma in our hospital, and going through the folders of those patients to actually see the days of admission, I saw that on the average, it was about 40 days. I had 60 days, I had 72 days, I had 28 days, and the average for about, I think, 6 cases between 2012 and 2022. The average was 40 days. So for this patient to have stayed for 30 days below the average of 40 days showed that this patient's stay was actually reduced. And also talking about investigation results, the wound swab and urine MCS. Wound swab showed Escherichia coli, the urine MCS shows Staph aureus. It was found that in those 2 test results, that ceftriaxone and levofloxacin was common to the 2 of them. That was why the choice was made for those 2 antibiotics. Although during care, the patient reacted to ceftriaxone, which was discontinued. But on the whole, clinically speaking, the patient's wound healed better and faster, even with levofloxacin alone, which is an indication that the MCS was well carried out. Thank you.
Thank you very, very much. I wanted to even ask you, especially concerning how did you implement your follow-up? Especially, these patients, you've been able to give a lot of care, and this patient has been discharged from what you are saying. So was there a follow-up from your end? Because in my facility, what we do is that Sometimes we take down the number of these patients. We do, or we take down the number of the patients' relative, because in my facility, the patient relatives are very, very much involved. They are very, very involved. So we take the number, and even if they are out of the hospital, we call from time to time to find out, especially when it comes to coming back to take their medication. They always give them, a time for them to come back. So we do follow up, and then we do medication review too. When they come back, we check, because sometimes it's not all the medication that we have in our own facility they buy. Sometimes, especially all these supplements and other, some of them, they take herbal medications and all that. So we want to check. Then we do some medication review. We check with, what they have been asked to get, with, what they have. Then we begin to cross-check if it's A that is there. Is there A there? And then how are they taking it? Is there supposed to be, then if there's any other thing that they are taking apart from those questions, sometimes physician may not ask them. So we take time to ask them, what other thing have you been taking since you left here? So we want to find out, and then draw the attention of the physician handling the case. Sometimes, because we are closer to the nurses, so sometimes we want to inform them, especially because they have the folder with them at all times. So how are you able to implement your own, how did you monitor this patient, or did it just end there?
Thank you very much for that question. In our facility, that's the University of Youth Teaching Hospital, we do a lot of follow-up as part of our monitoring and evaluation of our activities in the ward. Like I said earlier on, one of the pharmacist interventions was having to establish a very cordial relationship with both the patient and his caregiver, which was his wife. Phone numbers were exchanged. Remember, I said earlier on that this patient was discharged on an instruction to come back to the urology clinic 3 times a week, Mondays, Wednesdays, and Fridays, for the dressing of the penile and mons pubis wounds. So on each of the follow-up days, each of the clinic visits for wound dressing days, I usually take like 10 to 15 minutes to interact with them. We at home, they had called once and asked if there was any other medication to take to boost the patient's immunity. I had told them to adhere strictly on the medications that they were given, and that it would be against the treatment protocol for them to take any multivitamin, especially that which contains folic acid, because folic acid is contraindicated in cancer patients, and Kaposi Sarcoma being a cancer case. So that is part of the follow-up that I did on the patient after being discharged.
Thank you very, very much. At this point, I call on Dr. Joseph Madu, the National Chairman, SIPA National Chairman. I know you have some comments and some other contribution you like to make on this presentation tonight. Sir, you have the floor. Hello, sir. I'm calling on Dr. Joseph Madu, the National Chairman.
Okay, Dr. Timi, sorry, what did you say? I didn't hear you.
Yeah, I'm calling on you
Hello?
I'm just calling on you to make a contribution, and you want to address the House for the presentation tonight.
Okay, sorry, I joined in very late. We had another meeting this evening, and before I could come back from my office, I came in very late. I apologize for joining this meeting late, but let me use this opportunity to, first of all, thank all the participants, because I know that if the presenter is here and the participants are not there, it will be like the king who organized the party and nobody went. I decided to start calling people from the streets. But at least with the participants, we are encouraged and we are happy. Then let me now use the opportunity to also appreciate the presenter. We all know what it takes to prepare for a lecture and deliver it. And let me still say that we are a bit sorry for the low turnout of today's lecture. I know CPAN lectures usually have more than this in attendance, but I can understand why, and I believe that will be corrected next time. Mr. Presenter, we really appreciate you. May God bless you. Some of these lectures, if you are to collect honorarium, it will not be less than between 50 to 100,000. We all know what it means to read widely and even present to specialists like clinical pharmacists. Then the moderator, of course, and every other person. I saw somebody's name. She's a CPAN VIP, Colonel Stella Ibe, representing the Nigerian military in CPAN. I also saw her at this lecture. I want to use this opportunity to recognize her presence. And please, to any other person that probably I did not witness, everybody is very important to CPAN. May God bless all of us. Amen.
Thank you, sir.
Amen.
Thank you, sir. You're very welcome, ma. Thank
Thank
you
you. Thank you.
for joining us tonight for this presentation, and we hope to see
Thank
more of
you.
you.
Thank
Yeah.
you. I feel honored.
Thank you,
It's
ma.
a pleasure
do we
to
have-
be here.
All right. So
Thank
do we have
you.
any other comments, question, contribution, encouragement? Yes, Pharmacist Rachel Omayuku. Please, you have the floor.
Oh, good evening, everybody. Good evening.
Good evening. You're welcome, ma'am.
Thank you very much, presenter. It has been a very good and educative period. My question is, what role can the community pharmacists play in this kind of in this case, this Kaposi Sarcoma?
Sarcoma.
Because from the presentation, the setup is a hospital setting. So what will be the role of the community pharmacist in the treatment of this disease? What would the community pharmacist do if you encounter this kind of situation? Thank you very much. I hope I'm understood.
Yes.
Hello? Okay. All right.
Yes. Okay. Community pharmacists.
What's the role of the community pharmacist
in the management of
in the treatment of this disease? What do we do as a community pharmacist?
Yeah, okay, ma. So can you
What would
respond,
you
sir?
advise?
All right. Community pharmacists have roles to play in the management of Kaposi Sarcoma. Considering that the community pharmacists are usually the first point of call of patients' illness complaints. So community pharmacists, number one, have a role in identifying Kaposi Sarcoma in the first place. So when, as a community pharmacist, if you see lesions, hyperpigmented lesions on a patient's skin, especially those ones that do not go with conventional antifungal or antibiotic therapy, and you do a further probe of investigation, and the person is either HIV positive or has a history of immunosuppression, maybe organ transplant or whatnot, that identification just send the patient straight to the specialist, which is the hospital setting. The number two role community pharmacists can play is that these patients will come back to the community when they are discharged from the hospital. They are going to come in to get medications, both the ones prescribed in the hospital and over-the-counter medications. Like this, my patient wanted to pick up a multivitamin supplement. It is the role of the pharmacist with the knowledge of pharmacotherapy of Kaposi Sarcoma to be able to counsel these patients and their caregivers on the timing of these medications, and also on when to go back to the hospital when things are out of place.
Thank you.
Thank you very much.
Thank you very much. I think I like this your response. Yeah, the pharmacy, the community pharmacy has to identify. They have to. So, is this conditions like this? It's not out of place. They learn it too and know when it is suspicious. You know, since is a condition that shows on the skin, there is temptation to initially want to start to recommend some triple action cream and some medications. But if they are able to detect it early, they can refer and still do follow-up. They can continue with the follow-up to find out when the person is out of the hospital, what the patient is taking. And I remember there was a lecture like this we had, and in that lecture, pharmacist Fola Shadelawa was there. And she also mentioned how she collaborates with hospital pharmacists and also physicians just to follow up a particular patient. Maybe the patient came to her place for the first time. I can't really remember now, but she did follow up to the point that even after that particular patient, physicians always call her and want to find out some things from her. So I think community pharmacists are really, really relevant in all this, even though the case is an hospital pharmacy case, is a case in the hospital. We can see how the hospital pharmacist was very, very involved, very, very involved. And this is because of collaboration in your facility. Thank you very much. There's a question in the chat box. Question or a comment. Given the high potential for hypersensitivity reactions with Abacavir, it would be appropriate to especially educate these patients about this potential and counsel about action to take. I think did you mention something like this, our presenter, when you were talking?
I did not mention hypersensitivity with Abacavir. The one the patient presented with was severe nausea and vomiting, which is has a 20% occurrence with Abacavir and about 10 to 15% occurrence with lamivudine. The patient was counseled on his medication, but since it was necessary, before Abacavir was instituted, the patient had done a urea creatinine and electrolyte, and the creatinine was a little bit raised, about 160. The normal range for adult males is between 80 and 115. So because of that, tenofovir could not be instituted for this patient. So that was why the Abacavir was chosen in the first place, although it comes with its own adverse effects.
Okay, thank you very much. Sorry, I just want to ask. This is the heart of the presentation. Which of the units are you in your facility?
I am in medical pharmacy unit, that's the inpatient, the pharmacy unit that takes care of the patients in the ward.
Okay, medical ward.
Yes.
Okay. Okay, yeah. So your oncology patients, are they in medical ward?
Yes, our oncology patients are in the medical ward. They are in the surgical ward. They're not in the medical ward.
Yes, they are in surgical ward. It's just that your patient has your own is there is another condition that makes him there. So you are also
involved. Yes.
Okay. Then there's a comment again from Ewuga John. Can you unmute yourself and say something, Pharmacist John Ewuga?
All right, thank you so much, presenter. That's a very good presentation. Just thinking aloud, looking at the myriad of drugs that has been described and actually dispensed, I'm just thinking if maybe there are possibilities of drug-drug interactions because of the polypharmacy being played in those aspects. I don't know. Did you look at that?
Yes, yes. I looked at the possibility of drug-drug interactions, and I'm going to mention a few of them here. Um, there's an interaction between levofloxacin and the opioid analgesics, that is both tramadol and pentazocine. It, it, it increases the effect of the opioid analgesic, the side effect of sedation and respiratory depression. And there's a myriad of interactions with isoniazid on its own. Isoniazid interacted with about 5-6 medications in this therapy. So what we did was this: we did a medication administration plan, starting with the highly active antiretroviral therapy. Okay, the first drug was ondansetron. Ondansetron is taken 30 minutes before the antiretroviral therapy, and it's taken at 5:30 a.m. The antiretroviral therapy of abacavir, lamivudine, and dolutegravir is taken by 6 a.m. We have the levofloxacin is taken by 10 a.m. taken once daily. We have the cotrimoxazole that is taken by 12 noon. We have the isoniazid that is taken by 6 p.m. And for a drug like diclofenac that is taken 8 hourly, it's taken 6 a.m., 2 p.m., 10 p.m. So with this kind of staggered medication administration, as agreed between the pharmacist, the physician, and the nurse who was administering these drugs in the hospital, it prevented a whole lot of drug events, adverse drug events during drug-drug interactions. I had looked into it, and I made a list and shared it with the physician. That's what happened. Thank you.
Yeah, I think I want to agree with you because of the comorbidity. One cannot, all these drugs are kind of necessary. The pain, the ones for the pain are quite much. Apart from the tramadol, is also on pentazocine, diclofenac tablet, and also IM. And you also talked about suppository one time. So although the condition, just like he has said before, is one associated with serious pain. So that's why with the antioxidant, vitamin E, vitamin C. So it's because of the comorbidity. So this is where the pharmacist role comes in, how to space and avoid any kind of interaction. So Pharmacist John, have you been able to answer your question?
Very well. Yeah. That's very, very excellent. Thank you. I'm in love with that.
Yeah, he's a good presenter. Thank you so much, sir. I was asking because we have SIPAN has 15 specialty group, and oncology is one of our specialty group. And funny enough, this Kaposi Sarcoma is one of the presentation. Kaposi Sarcoma is one of the presentations that we may likely be doing with time. So although your patient, this is a comorbidity, and then from the diagnosis, it shows that the immune system is actually compromised. And when that happens, this kind of condition can easily just set in. So I'm just telling you this because we can invite you to do a presentation for us in any of our, especially on our oncology platform. So I hope when we call on you, you will oblige us.
I will.
Oh, yeah. So thank you so much. We are really happy that you featured in tonight's presentation. So if there are no other questions, no contribution from any of our participants today, I would like to call on our national assistant, our national Education Committee Secretary, Pharmacist Regina James, to give us a vote of thanks and round up our tonight's presentation.
Thank you very much, our dear moderator. Actually, before I say the vote of thanks, let me contribute to the last question that was asked. Hello? Hope I'm audible.
Yes, ma'am.
Yes,
You're very audible.
Okay. I want to contribute to the pharmacist John also that was concerned about drug interaction. I observed from his presentation that there are actually 24 drug items there. But I also observed that the patient was there for 30 days or thereabouts. So definitely those drugs were not given at the same time. Like the analgesics, for instance, the injectables were given for some time and then discontinued before the tablets were given. The same thing with others. All the medications were not given at the same time, even though the presenter has showed us how they monitor the administration. But even then, they were not taken, they were not given at the same time. So that could reduce the possibility of some of the interactions. Thank you. Okay, on that note, I want to appreciate our presenter so much, particularly for the case study, like he followed the patient, he monitored the patient, the drug therapy and all. I also want to particularly appreciate the moderator. Our moderator, Dr. Tini, she has done so well. If you actually check, she was not to moderate, but due to network issues, the moderator could not join, and then she took it up and did the moderation. We appreciate you so much, madam.
Thank you, ma'am.
And then we also appreciate all that participated, those that asked the question, because it is the question that actually made us understand the presentation better. So thank you so much. We appreciate the committee and everyone that participated. And then we want to remind us to please publicize our presentations in your states. Those that have participated today, you have seen what we have. This is what we enjoy every Friday. Please publicize in your states. Before now, we had said that there should be representatives from every state, a minimum of 3 representatives from every state, because this kind of knowledge needs to be shared with as many people as possible, many pharmacists, because we need to get involved in the patient care. That is what CPAN stands for, direct patient care. So in cases like this, we need to get involved with the patient in the ward, follow up the patient after discharge to optimize the therapy. Because if we just allow them to stay there in the ward and go at the end of it, like we have seen all the 24 drugs here, without the pharmacy, there could be a lot of issues with the medication. So I appreciate everyone. And then I want to remind us that next week will be the state meetings, the state clinical meetings. So please let the meetings be held in each state. As you go back to the state coordinators and other coordinating team members that are here, please be reminded that next week Friday will be the state clinical meeting. So once again, I appreciate our national chairman and all the executives for making these presentations possible. Thank you, everyone. God bless you.
Thank you so much, ma. We really appreciate you too for the work you have been doing in CPAN as our National Education Committee Secretary. Thank you, ma. At this point, we'll be having our closing prayer by Dr. Abdulmunim Issa. My Dr. Issa, yeah.
Hello, Dr. Timi.
Yeah.
Okay.
Yes. Please help us with the closing prayer. Thank you, sir.
Okay. Well, thank you, God Almighty, for bringing us to the end of today's clinical presentation. We pray that whatever we've learned today, we'll be able to put it into practice and use it for the betterment of our profession. Thank you, everyone. God bless you and good night.
Good night. Thank you very much, sir. Thank you
Good
all.
night.
Good night.
Good night. Good night.
Good night.
Good night.